Well, hello, and welcome to another edition of the Impulsive KetoCast. I'm your host, Ben McDonald. Today's episode, we have a special guest. Teresa Mealy is going to be joining us to talk about menopause. This is kind of a medical crossover show where we're going to be getting into the nitty gritty of what menopause is and what you can do about it to make your journey a little bit smoother. Just to introduce Teresa, she's a board certified family nurse practitioner with a focus on bioidentical hormone replacement. She's certified with WorldLink and works in functional medicine and thyroid management as well. She can be found at Teresa Mealy, totalhealthandwellness.com, and on Facebook. Teresa, are you with us?
I am. Hello.
Hey, look at you on video and everything.
Yep.
All right. Well, I'm excited to talk about today's topic because we know that there are a lot of women on social media, and unfortunately, that some of them are aging. Not all of them, but some of them.
Yes. I'm excited because this is one of my favorite topics.
Now, menopause is something that you'll need to explain to me because I don't know what that is. So can you kind of lay out what is going on here when we're talking about menopause? I guess there's a couple different phases.
Right.
And what is this?
So menopause definition, the technical medical definition, is no period for 1 year or more. So
Okay.
if a woman has a period, no period for 7 months, but then has a period 2 months and then goes another 7 months, she still isn't technically by definition in menopause. Leading up to that, there can be a great many years, like sometimes 10 to 15 years of perimenopause, where periods go wacky, hormones go wacky, moods go crazy, but you're still having periods. Sometimes they're irregular, but this time in between is called perimenopause, and that can wreak havoc for women as well.
What is the age when perimenopause starts to sneak in for women? I know it's going to vary by person, but
Women start to wane in progesterone and testosterone early, like around 30, 35. If a woman has something like, I know it's sad, if a woman has an issue like polycystic ovarian syndrome, their progesterone is much lower for most of their lives. So I would say women, for me, my own personal experience was right around 40, 41. I really started to notice something different. I think women can compensate for quite a while, but in their 40s, between 40, 45, they really start to notice something is not right, and I do need to figure out what it means or what I could do about it.
Okay, so when you're starting to reach into this age and you're seeing these symptoms, the expectation is that the pin is out of the grenade. This process has started, and you're on a long decline, 5 to 10 years, you're saying?
Yeah.
And then one day everything is going to stop and go to zero at that point, right?
Right. Exactly.
Why is that such a big deal? I mean, it seems it's perfectly natural.
Well, it is natural, but normal or normal, but normal doesn't always benefit us. So the reason it's bad is it's such a tricky time in our lives, because I know that we might talk about this another time, but it happens with men too. So you start to get, your kids are getting grown, and then suddenly you have these mood shifts and these night sweats and hot flashes, and your libido is down. And it just seems like at this point in your life, your world turns upside down. And so it just, for women, I think it hits us really quickly and kind of like just is right in your face, where men, it's just a little more insidious. So for women, I think, it just hits them. And then suddenly they're just like, something's not right. And meanwhile, everything around them is falling down, and it doesn't have to be that way.
So you've described this as being kind of a decline in the natural production of hormones. What can be done about this? Obviously, if you have less hormones, the answer is going to be give more hormones, right?
Right. Yeah. And so the reason we want to fight this, so a lot of times, especially if you have older women who are postmenopausal, they'll think, well, I don't have night sweats or hot flashes anymore, so I don't need hormones. But our theory or thinking is, and based on literature, is that we all do need hormones. We need to replace them because it helps prohibit or inhibit diseases of aging, like insulin resistance, diabetes, breast cancer, uterine cancer, Alzheimer's, osteoporosis. All of these age-related diseases could be prevented if we replace hormones.
It is interesting to me when, and we'll get into the science on this a little bit later in the show, but it is bizarre that there's no rash of 35-year-old women breaking hips, but somehow 65-year-old women seem to have a hip problem when they fall over.
Exactly. And it's also interesting that providers in this age group of women that are breaking their hips because of osteoporosis don't think like, I wonder what's different, or estrogen, maybe I need estrogen. And then they get told estrogen is dangerous. But nobody was knocking on doors of women when they were 20 something or in the hospital after they had their third or fourth child. Like, good heavens, are you done having children yet? We have got to get those ovaries out because estrogen is dangerous. That doesn't happen. And so really estrogen is not the bad guy. It's the imbalance of progesterone and estrogen that is bad. When progesterone and estrogen are equalizing each other out, there's not a big to do. But when there's an imbalance, that's when there's a problem.
So, the hormones is really your world, but just really at a very high level, can you talk about, is there 3 or 4 hormones that are kind of like the big players here so we can get a vocabulary lesson?
Sure. So for a perimenopausal woman, which is my age, so I'm 47, it would be optimizing thyroid. If you don't have a thyroid issue, it would be optimizing progesterone and testosterone, and then DHEA, which is a supplement that you can get over the counter, but we measure those levels too. So those are the 4 hormones for perimenopausal women: thyroid, progesterone, testosterone, and DHEA.
Okay.
When you get a menopausal woman who is finished having periods every month, you add in estrogen. So there's 5 hormones then for menopausal women, and that just includes estrogen. It takes a while though before we add in estrogen, because like I said, or maybe I didn't say it, but estrogen can make things really wacky if it's imbalanced. And many times, even after a woman has had a hysterectomy, if she still has her ovaries, she will go on to make an adequate amount of estradiol for 5, sometimes 10 years. So this is why it takes a knowledgeable provider to watch those estradiol levels. And when they fall enough, for me, it's usually around 50 or below, or if they start to have significant issues like hot flashes or night sweats. Also, in that time frame where we don't actually need estradiol yet, you can curb hot flashes and night sweats with progesterone and testosterone.
Okay, you are throwing out some more words here, so let me just kind of clarify that we all know it as estrogen, but estrogen has several forms of bioactive and bioinactive. You mentioned estradiol. Are there any other forms that we need to know about?
Yeah, there's estradiol is the one our body makes the most of when we are at our peak. And then there's estrone and there's estriol, but estradiol metabolizes into those metabolites. So we replace estradiol, which is E2, and there's also E1, estrone, and estriol, which is E3.
Okay. So primarily our focus is going to be on that E2 as we're discussing things. Okay, great. Okay, so each one of those hormones, the thyroid hormone, I know to be basically the metabolism hormone, right? That's the hormone that drives the body's basic metabolism and can be involved in weight gain, weight loss, and that basal thermo regulator, right? Is there anything else that thyroid does that we're particularly interested in?
Yeah, so thyroid also helps cholesterol and blood pressure.
Okay.
It also can help with aches and pains. It can also help with sleep. Those are the main ones in perimenopause and menopause. Those are the main issues that it would help with.
And is that something that is pretty common in perimenopause, or is that kind of hit and miss with folks?
It's hit or miss, but for me, it's optimization. So what I'm really looking at is free T3, and I want the free T3 up around 3.4 or higher.
Right. And to be clear on that, that's something that can affect folks even pretty much everybody is on a spectrum for that, and at different phases in their life and health, especially with obesity, that thyroid hormone can come down, and they could experience some of the, you mentioned PCOS, they could experience a lot of very strange phenomenon even earlier if this thyroid hormone starts falling off early due to health concerns, right?
Right.
Okay, so progesterone. Talk about what that does in the body for us.
I love progesterone. So, progesterone is the hormone of contentment. It is potent for anti anxiety, antidepressant. It is progestational, so it's not bad for you. We give it actually to pregnant women to help sustain pregnancy when they have issues.
Oh,
It
interesting.
helps, yep. It helps with, it's apoptotic to cancer cells, breast cancer in particular, which means apoptosis means it's cell suicide. So
Hmm.
it kills off cancer cells.
Right.
It helps with balancing out estrogen. So when you have an imbalance of estrogen to progesterone, estrogen is proliferative. So she proliferates or has a greater cell turnover. With a greater cell turnover, you have a greater chance of mutation, and
Hmm.
that is cancer mutation. So progesterone downregulates her proliferation, and that's how it also helps with breast cancer prevention. It helps with bones. So it improves osteoblasts, which are the bone building properties of bone health.
Okay.
We have osteoporosis medicine in today's world, like Fosamax and Boniva.
Boniva.
These
Yeah,
things only slow bone loss.
that's right.
Progesterone and estrogen build bone. So they actually build bone.
Hmm.
So you could have a terrible DEXA scan in a postmenopausal woman, put them on the hormones, the progesterone and estrogen and testosterone, and you'll see over each year an improvement in the DEXA scan and bone health. Progesterone also helps with headaches. There's a lot of menstrual migraines that are associated with low progesterone because, again, when you have that decline of progesterone, you have too much estrogen. It's not like your body's making more than normal. It's just that you're at a consistent level of estrogen for a really long time. But
Hmm.
progesterone wanes first, and then you get menstrual migraines, you get wacky periods, you get heavy, irregular cramping, clotting, bad PMS. Progesterone is also a tranquilizer, so it helps with sleep at night. One of my huge issues was suddenly I couldn't sleep. I had thyroid and Hashimoto's that was undiagnosed and mismanaged, so I could never wake up. I was always tired, and suddenly I couldn't sleep when I realized it was hormonal, which is, progesterone. So those are the main ones. The big misconception, even among GYNs, gynecologists who are supposed to know hormones,
Hmm.
is they will not give progesterone if you don't have a uterus. In their mind, they only give progesterone to oppose estrogen for uterine health. So if you have a hysterectomy and you have no uterus, many times providers will not give you progesterone opposition. And that's wrong because it's favorable to blood vessels, it's favorable to cholesterol, it's favorable to brain blood vessels, again, sleep and bone and breast. So a woman doesn't have a uterus, but she has a brain, she has bones, she has blood vessels, she has breasts that all need protection.
Sure. And we actually see when you look at to get into the science a little bit, we see a sharp increase in calcification in arteries of women post menopause only.
Mm-hmm.
That CAC test where they look at the calcium in your arteries almost always comes back completely negative until 55, 60 when you look at women populations. And this must kind of explain this phenomenon. Whereas men, it's kind of a gradual thing starting at about 40. It's a sharp increase where this menopause seems to kick in.
Right. And progesterone reduces foam cell formation, which is the macrophages that clump together and create atherosclerosis.
Yep.
So, also estrogen, I know we'll get to that, but I don't want to forget this. It's hugely important that women start on estrogen as soon as they start into menopause because it remodels plaque in your coronary vessels and you can reduce it before it gets to the necrotic cap and
Hmm.
break off and cause strokes.
Yep, and that's a huge thing that we definitely want to talk about. Now, you
Mhm.
mentioned something. I just want to put some vocabulary around something I heard is estrogen dominance.
Mhm.
Now, does that you were explaining how progesterone kind of falls first, and that
Right.
they need to exist in a balance, a ratio. Is that what providers are talking about when they refer to estrogen dominance? That this ratio has started to skew towards estrogen because the progesterone has fallen off first.
Yeah. And actually, I don't think the medical community or it's a real thing, estrogen dominance, but it is what we say when, your estrogen or estradiol production does not wane for a long time, but progesterone does. So then
Okay.
it just naturally leaves an estrogen dominance. Endometriosis, polycystic ovarian syndrome, many times migraines, those are all an estrogen dominant problem.
Okay.
which just means you aren't making enough progesterone.
But that makes sense, and I have to disclose that that term is mostly seen on social media clickbait,
Yeah.
but it is a term that people ask me about a lot, so I was
Yeah.
very curious about that.
And if I know we're talking perimenopause and menopausal, but women with polycystic ovarian syndrome from the get-go do not make enough progesterone because many times those patients do not ovulate, even though they bleed every month. They're anovulatory cycles. You have to release an egg from the corpus luteum to produce progesterone. So you can have a period but not be ovulating. And in those cases, if you don't ovulate, you don't make progesterone. And so those patients are already in their teens with polycystic ovarian syndrome at a deficit in progesterone. That makes them more susceptible to breast cancer, uterine and ovarian cancer or cyst on their ovaries. That is all estrogen dominance. That can be fixed in our practice with progesterone.
That's really interesting. In the nutrition world, when we address PCOS, we come at it from a standpoint of weight loss and glucose control.
Yes.
But the reason that works is because it stabilizes the underlying hormones and would allow the natural checks and balances to start to fall into line.
Right.
But it's often a very slow process. If someone comes to me wanting to know about the ketogenic diet and their PCOS, it's usually going to take 4 or 5 months of them being really strict before they see any symptom relief or any real measurable change.
Yes.
I had never really even considered that there may be a medical intervention that could bridge that gap while we work on getting the wellness back to where it needs to be so that these hormones just kind of go back to their normal status.
Yep. And definitely polycystic ovarian syndrome is an underlying insulin resistance. So you're right. The nutrition is huge for them.
Interesting. Okay. All right. On our vocabulary list, next up is testosterone. Why would you need that as a woman? I thought that was the dude hormone.
It's magic. So we don't need as much as you guys do, but testosterone for men and women is just zest and vitality and motivation and assertiveness and that energy. Like, I have to mow the lawn. Oh, I'd rather balance my checkbook or do anything else. And then it's like, oh, I'm going to go mow the lawn. And it's that I want to go for a walk. Do you want to go for a drive? Let's go to the lake. Let's go to the pool. It's just energy and zest and cardiovascular health. And for men, they get estrogen from testosterone, and that's where they get the bone health and the Alzheimer's protection. And it's insulin resistance. It's getting fat to lean body mass. It's bulking up your muscles without having to go to the gym twice a day, 7 days a week. So I think testosterone is huge. And in all of the literature, it helps with anxiety, depression, weight loss, insulin resistance. It's just the zest of life.
I gotcha. Definitely testosterone is a big part of my life. And I couldn't imagine what it would be like to not have that energy. And, when I think about how important that it is in the milieu, we've talked about progesterone kind of measuring with moods and anxiety. So now we're talking about testosterone that's kind of buffeting the energy, vitality, but also the strength and the body mass, the skeletal muscle. That's got to be such an important part of combating this aging process where you become frail. And that's what we want to avoid, these weak bones, the diminishing lean body mass. I can totally see how this is such an important part of the puzzle.
Yeah, it's huge. And it makes, especially for women, like men, even if they have low testosterone, sex drive never wanes. But for women, we're much more emotional. And if you have dishes and laundry, and it's like, I'm not going to think about sex, but testosterone helps that arousal, that initiation, and it makes orgasm much more intense. It's just a wonderful complement to a hormone therapy.
Okay. And DHEA. What is that role? You said I could buy that on Amazon, right?
You can. So DHEA is called the mother of all hormones. And for women particularly, it can convert a little bit to progesterone, estrogen, and testosterone. Not enough that you would bring levels up hugely, but that a lot of times when people leave my office, they buy DHEA in the office, they get their thyroid script at the local pharmacy, and then we have a compounding pharmacy out of Utah that mails the pharmacy or the hormones. before they even get the hormones in the male, and this happened to me, DHEA and thyroid, when I got on the right kind of thyroid, made a huge difference. So DHEA is the anxiety, depression. It offsets cortisol, which is the stress hormone. It's huge for immune function, autoimmunity. The pharmaceutical world realizes that it's so wonderful that they're making a synthetic version for lupus from DHEA compounds. And aches and pains, general well-being. I have people take it in the morning because it can just give you energy.
Okay. That makes sense. So it sounds to me like that's almost like a substrate or a precursor that just kind of optimizes your body's ability to make more hormones of whatever is in demand.
Yes.
Is that fair?
Yep.
Okay. Well, thanks for the vocabulary lesson. This kind of, you're going to be throwing these words around as we go down the rabbit hole here. So I want to make sure everybody understands when we're talking about the different aspects, what these chemicals are doing for you, these hormones.
Yeah.
Okay. So what is the best intended outcome? If you are someone who is perimenopause, it sounds like that there are some medications that can be used to kind of bring up some of these hormone levels. But is our intended outcome to be feeling like we're 28 years old again? Is that the goal?
Yes, that would be great. I already said I'm 47 and I've been on hormones. This will be my 6th year. And I have never felt better because I'd never felt good in my 20s because I had undiagnosed Hashimoto's, was always exhausted. I just feel so good. And I just hung up with a phone follow-up, and she said she's had breast cancer. She's like about 15 years out. She's had a hysterectomy. We have her on hormones. She said, I feel like Wonder Woman. I'm like, great, because Wonder Woman is really cool. So yes, the intended consequence is that we go back to how we were feeling in the beginning, when you were young, when you were feeling energetic for most of us until it starts to age. We're not going to make you live longer because that date is destined for you. You know, that's out of our hands. But while you're here, we want you to feel the best you can feel so you can enjoy your life. I mean, again, I'm 47. I had children late in life. I have twin boys that are 11. They keep me hopping. And at 47, I got to be hopping.
Right.
With 11-year-old boys.
Yeah, that's a lot to chase around.
Yeah.
Okay, so for someone who is post-menopause, someone who's 65 years old, the period is long gone, the side effects, hot flashes have settled down. What are the expectations for someone in that state?
Yeah, so we want to build bone. We want to protect blood vessels. We want to protect you against stroke, against high blood pressure, against increased cholesterol, against Alzheimer's. And then, like I tell people, the main things that people feel in menopause is hot flashes, night sweats, and dry vaginas. So they don't want to have sex. It's painful. So we want to erase all of that, not hot flashes and night sweats. We want you to get a good night's sleep. We want you having sex. We want you having orgasms, and we want your bones to be healthy, your brain to be healthy, your vessels to be healthy. So all of those things are hugely important. The best way is to start estrogen. So the best thing is to start hormones like perimenopausal, the progesterone and testosterone, DHEA, when you start to see a difference, 35, 40, 45. Okay. But we want to get you on estrogen as soon as you need it, because the earlier the better, because you prevent things. And then there are a lot of things. I'm trying to think, how much do I get into it? There's a lot of things in literature about stroke risk with estradiol or estrogen. Yep. That is actually, and you might have this in your list to go over it, but it's actually with Premarin. And the WHI trial shows that estrogen causes stroke. That is in older women. First of all, it's with Premarin, which is not what we use, but it's with older women who already have risk factors. So we want women to start at the earliest possible time, so you don't already have these risk factors in play and plaque building up in your coronaries, etc.
Right. And we definitely will talk about this a little bit more, but just to be clear, Premarin is not a bioidentical chemical. It's something close. But more importantly, as you hear Teresa talking about how these different hormones are so favorable to your cardiovascular system, by managing this inflammation before it progresses, you're not, this is a chicken and the egg thing of, yeah, you're at risk of stroke because your arteries have been under assault. They've been weakened. You've got these plaques, you've got these foams, these different, uh, all the little weird stuff that can go wrong with the arteries that can cause weakness and put you at risk. By being proactive and getting in front of this, you're not actually reducing or increasing your chances. You're reducing your risk of further progression.
Mm-hmm.
And
For sure.
that population is already self-selected as someone who wasn't on hormones before they started studying them.
Right.
So we know that those people had put themselves at risk up until the beginning of the trial. So of course, when you start watching them, they're going to be in a weird state.
Right. And those women already had cardiovascular events, but you and I know that, but other providers don't. And then they scare the bejeebies out of people when they go ask for hormones.
Well, so this is maybe a good chance to just take a step sideways and just at a very high level, we'll get into safety a little bit deeper later, but at a very high level, we all know that there are forms of breast cancer that are estrogen positive. So estrogen's bad. It gives you breast cancer because that's what it says clearly, right?
Mm-hmm.
So can you talk a little bit about, is there any risk of starting to supplement this as an exogenous compound versus going to zero? Because it sounds like if some breast cancers cause increased growth when they're exposed to estrogen, it would be better to keep it at zero. That's a pretty logical thing to say.
Right. Or you could balance out the estrogen with progesterone, which is apoptotic to cancer cells. When a woman does have breast cancer, then they get put on tamoxifen or Arimidex, and that's to block estrogen.
Right.
It's the same principle that progesterone does, except tamoxifen is a carcinogenic. It causes cancer in other places, i.e., women usually have to have their uterus out next because of cancers. So progesterone is all natural and can do the same exact thing. There's over 60 studies done on breast cancer survivors giving them estrogen or estradiol. Okay. And they all go on, because they're balanced, they go on to have less recurrence of women that don't start on hormones. So again, for me, it is not estrogen or estradiol that causes cancer. It's the imbalance that causes cancer. The imbalance of progesterone and estrogen. That is why, Ben, women my age, like 40 to 55, that's when all the breast cancers happen. And that is the prime time where we are deficient in progesterone and not opposing estrogen. So 5 years after tamoxifen or breast cancer therapy is done, we can start treating women again. And I treat several. I probably have 6 breast cancer survivors that I treat, and all of them are on estrogen.
Okay. Well, it certainly is a confusing thing. The more that I've learned about cancer over the years, the more I realize cancer we use like it's one thing and one disease. And it's really a very broad spectrum of so many different things. And that in most cases, anything that you can do to be protective of that from progressing is always going to be the best choice, because once you're in flight, you're behind the 8 ball. You want to be in front of it.
Right.
And if I understand you correctly, are you basically saying that progesterone is kind of competing with estrogen for these cells that seem to progress? Can you talk a little bit about the mechanism of how that works? I know that's super technical, but
yeah, no, it's just that so progesterone downregulates estrogen's proliferation, and it's apoptotic to cancer cells. So there's never been a study that even showed Premarin, which is the synthetic estrogen, or horse pee. Pregnant horse pee is where they get it from. Which, by the way, even if I wasn't in hormones, I would not prescribe that, because it's, terrible cruelty to animals, how they get it. But even Premarin, so synthetic estrogen, has never been implicated in breast cancer. It has been implicated in clotting, increased clotting risk, but not estradiol. Right. It's Provera, which is the synthetic progesterone, which I don't even like to call it synthetic progesterone, because it's not anything similar to progesterone. But it was Provera in the Women's Health Initiative that was stopped early because of breast cancer. So what they're trying to achieve, oncologists with tamoxifen, is the same thing we can achieve with progesterone. Okay. It does the same action. It's just without all the side effects.
Okay, that makes sense. And again, let's be clear. We're talking about hormones that the first 35 years of your life, you had a whole heap and helping of.
Hmm.
So these are bioidentical hormones, which are distinctly different than something like Provera, which is, this chemical that is loosely related to the actual hormone.
Right.
You can see the disgust on Teresa's face.
Yeah.
So let me just provide some color commentary here. One of the things that's interesting about Teresa's practice and her training is that she went to a school that is focused on bioidentical hormone replacement. These are practitioners who have spent their focus and research on trying to figure out how to use chemicals that are not different than what your body has. They're exactly the same thing. They are the hormone. They are bioidentical. They're not sort of like it. They're not synthetic. They're not pregnant horse urine. This is the actual hormone. And it's for that reason that a lot of these claims of safety and the lack of concern about how your body's going to react to these, because you're not bypassing these natural checks and balances that you have. You're using the body system that's already in place. You're just augmenting this diminishment of production as we go into this phase of aging, right?
Right.
Was all that fair? Do I need to add
Nope,
anything to
that's
that?
good. And also, Premarin, which is pregnant horse urine, does have 2 or 3 estrogens that are like ours, but
Yes.
there's 12 or 13 in all. So you're talking 2 or
Mhm.
3. The rest do not fit lock and key like bioidenticals do. So that's where you get weird side effects with Premarin, or the clotting and all, increased risk of clotting and all those other things, is that when it goes through the liver, Premarin has a significant higher estrogenicity than a bioidentical estradiol does. And that's where things get mucked up, is
Mm.
is because of those extra horse estrogens that we don't know what to do with.
You've mentioned clotting a couple of times now. Anytime you start tinkering with these female sex hormones, there are issues with clotting. I even remember in my wife's birth control insert that there was a big thing about if you were a smoker and on these pills, that you were at great risk of whatever, and you needed to stop smoking or stop taking the birth control pills because so many women had experienced clotting. It,
Yes.
can you talk? Do you know anything about why these hormones are so provocative to this problem?
It's in birth control is also synthetic estrogen. So birth
Okay.
control wipes out ovarian function. So it wipes out progesterone and it wipes out testosterone. And then
Okay.
it gives you back synthetic estrogen. So it's the same principle, that it's high, the estrogenicity is high. And so
Hmm.
it just doesn't meld well with our body.
Okay.
So you do have an increased clotting risk with Premarin, as not with estradiol, but with Premarin. However, Premarin isn't really that bad if you take away how they make it. After 5 years of being on Premarin, the clot risk goes down to basically 0. It's a 0.6 risk after 5 years.
Okay. So your body kind of acclimates to this. This is
Hmm.
how the hormone system is very robust in its ability to balance itself out. And
Yeah.
when I looked in the biochemistry books on this, there's chapters of just how complex the ability to aromatase this thing and bend this into different forms, E1 to E3, to try and protect in different ways. It
Yeah.
seems like it's very complicated, but also that it would make sense that it's so robust that as long as you're kind of being consistent with something, it's not too dangerous. Your body will adjust and adapt just like
Yeah.
anything else, right? Okay, so let's talk about in your practice as someone who is kind of from the World Link school, bioidentical hormones. What can I expect to walk out of your office from? Yeah, we've talked about the four. You mentioned the DHEA is a bottle of pills I'm going home with. The thyroid I'm getting from CVS, but then you mentioned a compound pharmacy. What's that all about?
Yeah, so we use MedQuest out of Salt Lake City, Utah, and they
Okay.
have a couple certifications that we like. And so they make it in a lab.
Hmm.
I remember this one GYN told my patient, there's no difference in bioidenticals. They still make it in the lab. It's like, yeah, I mean, everything, vitamin D is made in the lab too. I'm like, what does that even mean? But they make it to be bioidentical to what you need. And then We compound it exactly to what you need based on labs, and then they just mail it straight to your house. And every 3 to 4 months, they come refills.
Okay, so no one outside of your patients knows what compounding means. Can you
Okay.
back up and explain that? Because I actually don't even know either.
Yeah.
What is
So
that? I
for
know what
instance,
CVS is.
yeah. So for instance, progesterone is
Okay.
compounded with yams. So they take the yams and they break it down, and then they make certain milligrams. They can even compound thyroid medicine too. They can take a certain amount of T3, a certain amount of T4, and compound it like natural desiccated thyroid would be at CVS.
I'm sorry.
They're
When you're saying compounded, what does that mean?
like
I really don't know what you mean.
they make it from scratch.
Okay, so somebody's got a big vial or test tube full of progesterone, and then he's got a big vial of yam dust, and
Yep.
he's sitting down with a mortar and pestle and
Yes.
literally making magic happen right on
Yep.
the bench.
Yep. That's it.
And the advantage to this is it's dial a dose, whereas at
Right.
CVS, you either get the 50 milligram or the 100 milligram.
That's
And
right.
if you need 70, then you're out of luck.
Right. There is a bioidentical progesterone available at CVS called Prometrium. It is
Okay.
micronized like I do let occasionally, I'll have people that with money issues, they want to try it. When we end up, because we always end up going to MedQuest, it's night and day difference. S-Trace at CVS is also bioidentical, but it is not micronized,
Okay.
and the levels do not come up like they do with the compounded form. So I don't let people do S-Trace. I don't want to sound like a tyrant, but like if you're coming to me for advice, I'm going to say like,
Right.
we can't do S-Trace. We could try Prometrium, but again, like you're saying, Prometrium only comes in 100 or 200. Beyond that, that's all the choices you have. And if you don't have insurance, it's hugely expensive. Compounding pharmacies are much more manageable with money.
Okay, so I definitely want to poke at the money thing a little bit because I can tell that you are pricey to go talk to, right?
Yeah.
If I go to call up my Blue Cross Blue Shield insurance, they'd be like, "You're paying cash, and now you want these compounded things that aren't from CVS. You're on your own for those too."
Yep.
Is this a problem for people? So I guess talk about how money works when seeing a provider such as yourself.
So for us, you do get a lot for your money because we allot an hour time. Whenever you come in to see me, even if it's a follow-up, you get an hour time.
Okay.
And so there's really no code that we can use for insurance that would even, come close to what we're doing. When you leave my office the first time, you go over to our lab, we use Quest, and they draw about 16 to 19 tubes of blood.
Okay.
I'm hugely nosy, and so you get a lot that way. And then progesterone is roughly about $80 for a 3-month supply if you're taking, say, 300 milligrams a night. Estrogen is fairly cheap. It's about $65 to $70 for 3 months. And testosterone for women is extremely cheap. It's about $50 for 4 months.
And these are the compounded forms?
These are the compounded forms.
Okay. All right.
And
That's really not bad.
No, the first month it's bad, especially when you leave my office and you buy $150 worth of supplements, but those supplements last 6 months and 9 months,
Right.
but you aren't getting that every month. You aren't repeating that money out every month.
Well, and you're ordering all these tests because this is the thing that one of the reasons that I'm attracted to your practice and why you and I are friends is you are an evidence-based practitioner. Mm-hmm. You're not guessing. You're not trying to figure out, little this, little that. Let's come talk to me in 3 months. Right. No. That's not what you're doing. No. You're pulling blood, 19 vials of it, and then you're going to figure out exactly what that is, and then you're going to call it in, and some guy's going to get out the yam dust and make a very specific prescription for that person based on data.
Yeah.
And
it's so cool.
Yeah. I mean, that's pretty exciting. And that's what you're paying for. But it's confusing why an insurance company wouldn't be interested in sponsoring an evidence-based discovery and treatment of something that is basically inevitable.
Right.
We don't like that, do we?
Yeah. And I don't have an answer. I mean, I have flippant answers, but
Okay, cool. So is there anything, so you mentioned Prometrium might be a solution for people that are really tight on budget, but I got to be honest, if it's $80 for the compounded stuff, there's not a lot of money to be saved because that's a 3-month supply, you said?
Yeah,
2
and
months.
there's a few of my patients, like their husband works at the railroad, and I can't think of the other people, but those people have like a $10 copay for a Prometrium. So I'm like, yes, let's do that.
Oh, okay.
But if you're
Interesting.
somebody like me, I have a cost sharing Liberty Direct insurance, so they don't pay for prescriptions.
Yep.
That Prometrium for 1 month is about $110 at the pharmacy.
Oh, okay. All
So
right.
if
Well,
you
that makes
have
sense.
fantastic prescription insurance, fine. But if you don't, then the compounding is the way to go.
I see. So for people who have that prescription coverage, it may be worth investigating just because in the long run, that'll be covered.
Right.
But the other two are not going to be covered either way, right?
Yeah, testosterone in women is not FDA approved, so will never be
Okay.
approved by insurance. Estrogen, they usually just want to do Estrace at the local pharmacy, which is just no good.
Okay. And are these pills, creams, patches? What are we talking about here?
So we use estradiol oral,
Okay.
progesterone oral, and testosterone as a cream. Women put it on their vaginal area.
Okay.
There's been quite a few studies that have been done on cream progesterone, and when they do tissue biopsies of the breast and uterine tissue, there is no progesterone to be found there, and that's where we want it for cancer protection. So we prefer to use oral. Plus oral progesterone is when you get the sleepy side effects, which, we like. I like.
Yeah. Are there any now you mentioned DHEA is kind of over the counter. Are there any other non-hormone prescription things that you like? I hear about black cohosh a lot, DIM, any of the primrose oil.
Yeah.
Does any of that stuff actually work?
I think it does. And a lot of times patients do that until they get to see somebody like me.
Okay.
And they say it helps, but then there's truly nothing like getting a individualized dose of estradiol made for you and sent to you and what you're taking. But yeah, all of those things can help. Progesterone cream that you get at the health food store can help a lot of women with symptoms, so it's a good place to start if that's where you need to start.
So I can buy progesterone cream at a health food store, and it's the real stuff.
Yeah, in like Young Living, I use Young Living oils. They have a Progestins Plus progesterone oil.
Okay.
So yeah, for a lot of people, it helps, but just you would see a difference if then you switched over to the kind of plan we do.
Okay.
But for some people, that's what they need to do.
I guess I'm surprised to hear that because things like testosterone and estrogen are highly regulated, requiring forms of paperwork and prescription, whereas DHEA and it sounds like progesterone are not actually that regulated, but they're also much more difficult to get at the right doses and delivery systems. Right. Okay, that makes sense. Okay, so let's talk about the risks a little bit. Okay. What are the downsides of going down this road? Well, we've talked about bone health being a huge thing, muscle, energy, libido, getting rid of those hot flashes. Those are all the quality of life things that are favorable. But as everyone knows, there's no free lunch in nature. So are there risks? Are there concerns by opening this door back up to staying on hormone replacement? Is there something that we would want to watch for?
I think the biggest risk is not you're not looking for this, but is money, because this is a lifelong commitment, and so you can go off anytime. You would go back to making whatever level of hormones you're making, but that's usually the biggest obstacle. But otherwise, progesterone, the main side effect is sleepiness, which is why we use it in the oral form, because it's most perimenopause and menopausal women need that for sleep. The big issue with progesterone, there's really no side effects. I know that sounds weird, but there are some women that will have bloating in the beginning. There's some water retention associated with it that usually goes away very quickly. There's about 1 or 2 women per 200 women that just cannot tolerate progesterone in any form. And then we have to do vaginal suppositories, which aren't as effective, but at least will give you something.
Okay, so hold on there. I just want to clarify what you said. So the oral progesterone that is globally diffuse. And you mentioned before that you like the oral because you were able to see it in the breast tissue and the other things that would be favorable to cancer prevention
Mhm.
versus the cream. And you're saying for some women that is not tolerable, and you want to go to the focused tissue suppository that kind of hangs around in that one area.
Right. And I have not come across any women that have been significantly allergic or intolerable to progesterone.
Okay.
The main thing that happens is the weight gain. It happened to me and it just went away. It goes away in about 3 to 6 months. If that also happens, you could also use what's called a rapid dissolving tablet of progesterone. It just dissolves under your tongue, or a troche. You won't get the sleepy side effects, but you'll still get all the benefits of progesterone. And then if a woman can't do either of those, then the vaginal suppository is what we do.
Okay.
And then, go ahead.
Are there any specific risks for existing health conditions? You've mentioned hysterectomy. Obviously, some women are coming into this having tried other solutions that often include some pretty serious surgery.
Mm-hmm.
Are there any changes to your approach or things they need to be aware of if they're coming into it with a partial or total hysterectomy?
No, we just do everything the same. Those people would just, depending on partial hysterectomy, how long ago it was. Like I have one woman with one ovary and she's still producing sufficient amount of estradiol. So that's the only part is estradiol. You have to know when to add that in.
Okay.
And let me just say this, there's lots of times people will make their way to me finally, and they've tried bioidenticals. Everyone does do bioidenticals differently, just like a regular provider, say for instance, treating hypertension or blood pressure issues, start with different medicines. So it does make a difference how you do things, the approach, the dose, the route, all of these things make a difference. And so many times people will come to me on such a small dose, but it's enough to prevent hot flashes, night sweats, and dry vagina, but not enough to build bone, prevent cardiovascular disease, and all this other stuff. So if you are listening and you think, gosh, I tried hormones and didn't really help, I would say try again, because we just do it different. People do it differently. I myself like it because I'm on it, and my husband's on bioidenticals. So I practice what I preach.
In another show, you and I have gone deep into the thyroid world, and I was very intrigued to learn more about sufficient versus optimal as a philosophy. It sounds like this is the same kind of thing where there might be enough to take the edge off, but there's a much greater range to really provide that all those great benefits that you mentioned at the top of the show.
Yeah, and there's levels. We go over in the office, but there's levels in the literature that show what needs to be the serum level to make these changes. And these are randomized, placebo, double-blind, controlled trials.
And again, that's why you're pulling 19 vials of blood, because you're actually looking for the specifics.
Right.
So it sounds like I'm going to see you. You're going to pull a bunch of blood, get me dialed in with what the data says, and then you're going to keep monitoring that periodically to make sure that I'm at those levels that you would want to get those idealized benefits at.
Yeah. We run labs every 6 to 8 weeks until we get things stabilized. Men go much quicker, but women we're much more special. And it takes a little longer too, because we have more hormones to balance. But yeah, we're closely following you. And also, people like me, we have good self-pay prices we work with Quest and other hormone providers. The consults and things that you do a lot of times will include labs. And so things are very reasonable. I think we're just used to using only our insurance, and it's kind of scary, but it's very reasonable.
Now,
for what you get.
One of the things specific to your practice, since you mentioned that, it doesn't sound like you actually need to see me and put the stethoscope on my chest in order to do this work.
Right. We don't do physical exams here. We in fact have you sign a consent that says you will get physical exams and have your own primary doctor, but we just look at lab levels and symptoms.
So are you doing telemedicine for a lot of your patients?
Sometimes we do telemedicine. We have patients from other states.
Yeah, I know the laws are very tricky on that, but for someone who's in your state now, you're practicing in a couple places right now, right?
Yeah. It's mostly Missouri. And so, yeah, people will drive from Kansas City or St. Louis or Oklahoma to see me once, and then we can do the rest by phone or email or Skype or any of that.
Because once you've established that initial relationship, you kind of know what you're dealing with, and then it's just tweaking by the numbers, right?
Yeah. Yeah.
And these lab tests can be done pretty much anywhere, right?
Anywhere there's a Quest.
There's a Quest in every major city in the nation.
Yeah.
So you're just phoning it in, and you just take your little sheet down to your Quest lab that you didn't know was there in that strip mall.
That's right.
Well, that's not so bad.
It's not.
Now, for people who aren't in Missouri or Florida, what do they do? Because obviously you're the best. I mean, there's obviously the best choice would be to take the drive. But for folks who can't do that, what's in it for them? What do they do to find a provider or to try and make this connection, especially for these folks who have been struggling with their GP that's throwing MPA at them?
Yeah. I would suggest going on WorldLink's website. It's worldlinkmedical.com, and you can look for a provider in your area that has been certified in hormones.
Okay.
And again, I go to conferences a lot, and I talk to people, and not everyone does it the way I do it or the way we were taught there. So, if you don't feel like you're getting what you want or what you need, then try another provider. I know it's like more money, but there's someone out there that's a great fit for you.
It definitely seems in this realm of functional medicine and optimal hormone status that there is a connection of both the intuition. I'm friends with a lot of your patients as well, and they talk about you have an intuitive approach, a database approach, and that gives you a certain edge on other providers. And different people who are trained by the same folks have a completely different take on things, because that's the thing about you doctors is you're all doing different stuff. Mm-hmm. And you'll take the same information and kind of make your own decisions based on your experiences and what the best outcomes always are.
Yeah. Yeah. And sometimes it's just a gut feeling I get when someone's in here and I probe things a little bit more. We pride ourselves because we run a little missionary here. So sometimes we just sit and pray with patients. We definitely have marriage counseling in here a lot, even though I'm not a counselor, but we have lots of couples. The women usually come first, then the men follow. So I remember one day in particular, I was just going over the one woman's blood work, and we just ended up having a counseling session. And so we do a lot. We talk about weight stuff here. We talk about stress. We talk about families. We talk about kids. It's not just hormones and in and out. We truly care about all of our patients. And, it's just a different kind of practice here.
And there's so much to it when you start looking holistically at a person, not as a patient or disease state, but how are we in this state? What is the general wellness? Someone who's overweight and 50 is in a completely different realm of possibilities than someone who's thin and fit at 50. And you've got different approaches that are a stressful marriage, a hard job, working night shifts. All those things contribute to these biological phenomenon. We talk about that all the time on the Facebook group about all these weird things that you wouldn't think have a direct effect on biology, but they most certainly do.
Right. And so for us, we know, so functional medicine is a systems approach or a patient-centered approach, not just disease reaction. So we're not just waiting for a disease to come and then throw a bunch of meds at you. We're trying to prevent things. For instance, I have this one patient who is married to a narcissistic man who is not very nice to her, and she has about 7 or 8 kids. So I talked about divorce with her one day. I'm not an advocate of divorce, but sometimes even counselors will be like, she said, divorce is off the table. So I said, okay, then let's manage and make sure every other aspect of your life is at peak performance. So then you can better deal with the one part that is not at peak performance. Mm-hmm. So these are the kinds of things that we get in with our patients. This morning, a patient who's doing fantastic on levels, but not so great, symptom-wise, because her son, there's a bunch of stuff going on with her son, which again, we cannot fix that. So we have to manage sleep and all the other parts that we can. And this is how we delve in. I know people's kids' names. I know what people's husbands do for a living. I know so much that we delve deep with our patients. We really are a family community in our practice specifically.
And this is why you have the audacious domain of total health and wellness rather
That's
than
exactly right.
Just Teresa's hormones are us.
Right.
It does make sense. I'm really interested to hear what folks, how they react to this information, especially when we start thinking about what does it mean to actually get on this track to move away from traditional medicine, where you're going to have about 4 minutes with a doctor who's got their back turned to you, cranking in that EHR,
Hmm.
typing all your traditional symptoms, coding you out, and then throwing your synthetic estrogen at you and saying good luck.
Yep.
So I'm very excited that there's alternatives. Certainly, some of the daunting things. There's a lot of spooky talk about risk. Hopefully, we've started to open the curtain on why we dismiss most of those claims as being spooky. And obviously, Teresa's doing it herself. So, uh,
Yep.
she doesn't appear to be under any problems. I think if it was that risky, you wouldn't have so many doctors. Most doctors are their own patients when it comes to this stuff.
Hmm.
I don't know any functional medicine doctor that isn't also a patient of hormone replacement therapy,
Yeah, exactly.
because this is it. Once you learn this, you can't unsee this, that this is how this is supposed to work.
It's exactly right. We have quite a few physicians in my practice that we treat.
Yeah, it makes sense. I mean,
Hmm.
why? Of course you would.
Yeah.
Okay, Teresa, any closing comments you want to make regarding bioidentical hormone replacement, or especially for someone who is kind of on the fence or a little daunted, both from the financial and just having to find a provider that will actually listen? We run into the same thing in the thyroid conversation of it's just so daunting to take that first step. Is there
It
any
is.
kind of nudge or commentary you could do to maybe invite someone towards that?
I would say to take a real assessment of what you're worth. If you're really feeling so poorly that you want help from someone like me, but you think you can't afford it, I would just say to really think about what your own worth is, because it makes you a better mother, a better spouse, a better daughter, a better friend. I mean, it just makes your whole life better. So when you think like, oh, I got to come up with a consult fee, and we're membership, so it's a yearly fee also, you don't ever pay when you come in, you think that's so daunting. I would just say to take an assessment of your worth, because we are worth it. Now, I'm not saying neglect house payments and stuff like that, but I am saying that many times we can find areas where we can cut back in and make a way. And then I would also just say, if you went on my Facebook page, I have a ton of videos breaking down each hormone that you could just get more information on. And do not take what your provider says for face value. And that goes for me. So even though I think I know what I'm talking about, or I'm passionate about what I'm talking about, it's your due diligence, especially with the way the internet is. You could find anything. You could go buy the med school books that med students are reading. If you
Mhm.
really want to learn about something, it's out there. So many times your doctors will poo-poo hormones and they will tell you they're dangerous. I have patients all the time that get told you're stupid, you're going to cause yourself cancer. You have to be, educated enough to where you can say like, that's not true, or thanks for that advice, or I'm going to fire you and find someone different. There are people out there. I would just say we are worth it, to try and figure out a way.
It is interesting. There's a book that you recommend.
Hmm.
How do you say that guy's last name?
Rousier.
Rousier.
Yep.
Now, he has seminars that you can even buy on the internet for a few $100, where he talks about it, kind of an introduction to the same training that you were given.
Yeah.
But there's a book that he's written that's pretty good, right?
Yes, it's How to Achieve Healthy Aging. It's so simple. He's very repetitive. It's very like basic grammar. You can understand it. It's a great read.
Okay. And we actually looked on Amazon. It is up there. It's about $20. And
Yep.
we'll put a link in the show notes for this so that you can find that book if you're looking to do that extra research
Hmm.
and equip yourself to understand what your options are, and to maybe may be equipped to make that intellectual decision to come in and see a specialized provider like Teresa.
Yep. I would just say too that when your doctor tells you that, or your provider, nurse practitioner, whoever tells you that hormones are dangerous, they're thinking about Premarin and Provera, and we don't use
Mhm.
those.
And that is one thing that maybe we do need to underscore is that there are a broad range of medications out there.
Hmm.
And some of these do have some really unusual data that make them a little spooky.
Yeah.
And one of the things I've asked Teresa offline about all these other crazy medications that are out there. And she's like, no, I don't use that. I don't know anything about it. And you start getting into it, and it's because there's a very safe lane. There's a nice road that Teresa's found, and she's focusing on those medications and not messing with these ones that are not great.
Right.
Whereas if you ask a general practitioner, that these are different medications than what Teresa's using, and they don't even have the option of going this route. Like, you could ask a general practitioner for permethrin, you're not going to get it. I mean, they don't have it.
Yeah, one patient we saw from Kansas City, it's been probably 6 months now she's been with us, but her doctor started to like kind of moonlight, if you would, to like on the side, do this stuff in the hospital that he works for now, says you absolutely cannot touch that.
Oh.
So she had to go find a different provider.
Oh,
So they're
nice.
really, hands are tied at a lot of places.
Yeah, because you've got all the standard of care things where everybody has to get the same medications for the same code, right?
Yep.
All right. Well, with that, Teresa, let's go ahead and put a cork in it, and we'll call this the Menopause Show.
Love it.
Thanks, Teresa.
Thanks, Ben.